Good evening. I'll take you through delay in confirming suspected treatment failure and switch to second line. That is what you observed back in Kenya in the facilities which we support as FACES, which is a collaboration between Kenya Medical Research Institute and University of California, San Francisco. We've been in operation since 2004, and we work in 4 counties. We support PITC, that is a provider-initiated testing and counseling, PMTCT or EMTCT, HIV care and treatment, and VMMC. The background of the study, really routine monitoring of viral load has been introduced in Kenya, and we know we use it in ensuring that clients who fail switch to second line. But targeted viral load is still being used in most of the resource-limited settings. And from the places we work in 3 resource-limited settings among the 4 counties which were listed. We know there is limited data on delay in confirming treatment failure in sub-Saharan Africa. Objectives of this particular study was really to evaluate delay in confirming treatment failure and switch to second line, and to identify reasons really for the delay. Methods, it was a retrospective cohort study, which was done to patients who were done for viral load between 2005 and 2011. We did it in 24 facilities, and the cohort we identified from viral load database. Inclusion criteria were viral load done to confirm treatment failure, and all clients who are having viral load more than 1,000 copies or equals to 1,000 copies, and all were supposed to be on first line. We did demographic, we took demographic, clinical and laboratory details from the patient charts. And this, just to inform you, the analysis was conducted prior to implementation of routine viral load in Kenya. Statistical methods, the count, percentage, mean, median, were used for descriptive analysis. Cox proportional hazard regression, and primary outcomes were really to check time from clinical or immunological failure to viral load testing, and time from viral load testing to switch to second line. That is a descriptive statistic. Those are some of the variables which we checked. And you can see female constituted the highest percentage. Age for adults was 37, interquartile range of 29 to 45 PIDs. Around 9 years. We checked distance from clinic, those who are coming 5 kilometers or less than or more than 5 kilometers from the clinic in different levels of health facilities. We checked also median time on first line, CD4, defaulting, WHO staging, and type of failure. With the Cox regression model, for time from failure to viral load testing, there were 2 variables, and that is with the use of univariate and multivariate analysis, years on first line. And this one showed that the more or the longer you are on ARVs, the shorter the time for viral load testing. The other variable, which also was significant, was number of times defaulting. So this one just shows that defaulting delays viral load testing. We also analyzed the model from time from viral load testing to to second line switch. And from those particular variables, there was none which was significant. And also we checked between clinical immunological failure to switch to second line. And also there was none which was significant. This slide will just show you the median time between clinical to virological testing. It was around 70 days. That is more than 2 months. And between viral load testing and switch to second line was median time of 56 days. And this is more than 2 months, around 2 months. Then the median time from clinical immunological failure to switch to second line was 143 days, which was more than 3 months. So the concern was about the delay in confirming treatment failure. And some of the reasons which came up, 47% was attributed to clinicians, or the clinical factor. And what came out were clinicians, some of them could not identify the failure in that they don't check the previous clinical notes. Because you'll get in a clinic, maybe one clinician is not the same person who will see this particular client the next DCA visit. 18% was attributed to system factor. Viral load turnaround time. It was really interesting to get that we get results more than 5 months. Then 17% was attributed to patient defaulting. And in most cases, I know we always blame patients that they're the ones who don't come to the clinic. But if you see from the percentages, we as the clinicians, we are the ones who will turn around the picture, which we are seeing right now. In conclusion, significant delay observed in confirming and managing treatment failure. We know that we need to strengthen longitudinal patient follow-up and retention. With the introduction of routine viral load, this is kudos to the change of the guideline. We should now be on timely. We should take timely action on those who failed treatment. And this particular study also helped us as a program to inform us and to make us think differently, and also ask questions on what do we do differently. Do we do things the same usual way, or do we change our approach to managing of these clients? And as a program, we did mentorship trainings in collaboration with the National AIDS and STI Control Program in Kenya. As a program, we employed more healthcare workers because what was coming up, clinicians were saying that there is burnout from the dispensaries where you get one nurse overseeing more than 1,000 clients enrolled in the clinic. And those are some of the challenges which you get in resource-limited settings. I want to acknowledge the listed and thank you so much.